So I'm here to declare dawn of a new era. And why? Because I've seen hundreds and thousands of patients from different walks of life. I've seen patients who, on Skid Row in Los Angeles, homeless for 10 plus years. I've seen folks who were homeless for 10 minutes. Seniors are particularly interesting simply because when I was managing 28 clinics across California and Texas, delivering primary care, mental health, substance abuse treatment services to over 100,000 patients that were largely lower socioeconomic populations, I saw the struggle in these eyes and the brightness behind them once we were able to actually provide them with even a little bit of access to care. I went to Cardinal Health, a Navi Health organization at the time, and I was able to work with Dignity and HCA hospitals, 14 of them in Southern California, to administer the bundle payment program in Medicare. And essentially, I was responsible for over 50 skilled nursing facilities and how they performed once they discharge a patient to the home, or to the skilled nursing facility, or to home health with home. And that was a very interesting exercise, to say the least. You know, we made several millions in one market, lost several in another market. That's when Humana heard of me and recruited me to oversee network and contracting for the west side of this country. And when I went to the health plan side, you guys, I saw levers of opportunity that providers typically don't see. And so throughout this session, I want this to be a not-so-session-y session. I want you to ask questions. If something excites you, jump in. Or if you have a solution that you're having trouble with bringing to market, jump in. Why? Because when I left Humana, I started Carenodes. Carenodes essentially, has really developed into a managed service organization, a digital health MSO. Right now, we cover about 51 million Americans. We have 10 medical groups under management. We provide Alzheimer's care, post-acute care, homeless care. We provide a number of different elements of care that nowadays are being pushed to home, hospital at home. And the concern that I was having was that, while all the care is being pushed at home, how about those that don't have homes? And how about the rapidly aging population that was next stat? 1 in 5, I honestly think it's a little bit more, I think it's 1 in 4, but the stat that I could find in the most solid way, 1 in 5 Americans are going to be 65 plus. There are going to be more 65 plus than 18-year-olds by 2030. And that means, no matter what I do, I don't think I'm exempt from aging into 65 and over. And so I'm personally concerned about the availability of healthcare when I might need it at that age. I don't know if you've ever felt super sick and kind of helpless and thought to yourself, my God, good thing I'm not 80-something, then what would I do in this condition? At least I know I could get better quickly. It's at the most vulnerable times of our current fully able existence that we need to think about when we might need care at our more vulnerable times. So if the industry is to follow anything, it's to follow these trends that are just starting to kind of stimulate the discussion between payers, providers, digital health organizations. And we've been very successful at Carenodes with our ecosystem, getting health insurance contracts to be reimbursed for services that are traditionally not considered reimbursable. For example, food. For example, socks that monitor diabetic foot ulcers and alert us in an event that there might be an exacerbation so that we can save valuable feet. And I want you to think about these seniors at home. Quite a bit of them are alone. How are we monitoring them? I mean, all these cute RPMs and CCM, right? So remote patient monitoring, chronic care management. all these remote care modalities, are they really user-friendly? Because when I look at my iPhone, and my grandma has a slightly larger iPhone, she has a really hard time managing that device. I have a hard time managing that device sometimes. And to expect our seniors to utilize the devices that Silicon Valley or these great engineering folks know how to develop, for them to utilize products that are created by 25-year-olds, so to speak, there's a fundamental disconnect between the producer or the supplier of service and the recipient. And that issue has been exacerbated by our third-party payer system because the patient ultimately isn't the one who's buying, right? Ultimately, it's the health insurance that's paying. So all the marketing, all the strategy is targeted towards the health insurance companies. But with something like ambient assisted living, when you have sensors at the door, for example, of grandma's bedroom, and we know that if grandma doesn't get up and walk out of that door one way or another within a, 16-hour period, then we might want to know about that. So ambient assisted living these are features that are embedded into the existing home of the senior citizen or the patient, and they passively monitor activities that might be that might otherwise indicate an issue, right? So if grandma isn't getting up, and all you have as a solution is a map by her, because there's a solution that is it's like a map by the bedside, and so if the patient steps on it, it'll quickly try to read a temperature or weight measure or something. But people slip, right? Those mats are not always there. I had a patient with dementia who used to like to really reorganize our home all the time. It was so sweet. She would do such a great job. But she's reorganizing the care infrastructure that's been put in place. And our nurses were going, they're really anxious because there was a lot of, escalations coming from that unit. Smart wardrobe addresses some of that issues. So smart wardrobes, these are socks, specifically siren socks. Siren socks invented by a woman in the United States, USA made. And essentially you wear these socks. They have sensors woven into the thread of the socks. And they're so comfortable that these patients wear them on average 12 hours a day. Even Florida patients, 12 hours a day wearing socks on average. 91% of amputations avoided. Why? Because we know the ulcer is forming even before the patient does. And so the 24-hour care team reaches out, intervenes, and they save legs. So no matter how much, I should have thought of a pseudonym, Jane, our favorite patient who likes to reorganize a lot of things, she was wearing her socks. So she's walking around, getting her activity in, reorganizing, and we're able to cross-reference the signals that are coming from that unit so that the patient isn't getting calls from this coordinator and that coordinator and another coordinator. So kind of coordinating the coordinators and taking the human touch points out of the monitoring as much as possible and embedding the humans for verification and validation is how we're able to scale the workforce of the future to care for the population of the future. And when I say future, literally I mean like tomorrow, right? Because this has been going on since 2010. The demographics have shifted to such a rate that 10,000 Americans a day are aging into Medicare. That started 2010 through 2030. But how about those that don't have homes and cannot have fancy sensors embedded in the frames and don't have the luxury to reorganize the mat from one place to another and make our care coordinators nervous? Those without homes, do they not deserve care at home? Because care at home is really a concept, right? Yeah, it's a setting, but it's a concept. It's a concept of, okay, age in place, age in grace, stay comfortable. And when major buyers like Humanas and the Uniteds and the Aetnas and you name them send signals, yes, care at home, then the industry rushes towards responding to those signals to the detriment of those that don't fit the criteria of having a home. So I worked with, I was a co-founder of a nonprofit called Cardboard Origami. 10 years ago, we started this organization providing portable temporary shelters to those who've been displaced either due to natural disasters or poverty, using the art of origami via a cardboard material set to open and close this unit in less than a minute. And it's waterproof, it's insulated, it's highly portable, and it's part of a program to streamline folks into permanent housing. So no, it's not just, patented sexy shelters we're handing out to make things a little bit more comfortable on the street, but it's part of a program to streamline folks into permanent housing, and these units are used on private grounds. It's step one. Step two is your care navigator, care coordinator, whatever you want to call them. We call them housing navigators. 3 is placement into permanent housing, and 4 is employment to sustain that newly housed status. It's not simply enough to, here's your caseworker, Godspeed. But here's your caseworker, Godspeed, here's, employment resources, here's, making sure that we provide the wardrobe for them to be able to stay employed. It's not just enough for one interview. And we've been able to successfully house and employ 5 out of 6 participants for 3+ years using this approach. So homelessness is really a chronic condition for some, and it should be treated as such. And it should be looked at as a health issue. Versus what we do right now is a moral failing is how we look at it and we try to ignore. I do. When I'm in LA, when I exit the freeway, I'm just overwhelmed by the off-ramp. So yeah, I'll look around. I'll try to ignore. In my head, I'll be like, am I helping in other ways? But it makes us feel bad. And so we should leverage our human emotions and our affect to channel them into solutions that will generate revenues for us and also positive social net impact. Cognitive health is something that is a major discussion point right now, but yet little to no solutions are available. It's entirely complex. And for every 10 new telehealth company I see, I've seen maybe one dementia-related organization. I'm hoping I'll see more than one by the folks that are in attendance today. They'll say, I'm working on this. But we talk a lot about mental health, right? Nowadays, mental health. But mental health and cognitive health are very, very closely related, right? So when you have depression, you can't sleep well, or a number of reasons. I'm just giving you one anecdotal, vignette. Then you start to form these plaques. I'm not a doctor, but they tell me. You start to form these plaques. Your depression leads to habits that are not exactly great for your cognition and your cognitive health. And so when we have all these seniors aging to the rate that we just talked about, and you have fewer 18-year-olds than you have 65-plus-year-olds, cognitive health, we're assuming that everything will be intact. That's our working assumption. We're not thinking about the workforce that needs to take care of these folks, including probably myself, due to family history. Is anybody working on workforce supply here? Anybody working on workforce supply? I see the hands are going up very, very, very slowly. So as you could tell, there's a huge issue. So Carenodes, we have a network of 134 healthcare providers, national network, multi-licensed, multi-specialty. And what we do is we allow health systems and largely startups to access our network of providers, just kind of like a health plan model would, a health plan network access model would be. What this has done is allows us to enable access. The medical groups are able to kind of rent our provider network. You know what you're talking. She knows what's up in this industry. Able to rent the provider network and scale this supply up and down on a monthly basis so that they're not stuck with a huge payroll suddenly and they can't get patients or they don't have enough work for their providers to do. We actually now provide for 10 medical groups a full network. So while those medical groups are paying us less than what we're paying our providers, we're able to pool these resources together and enable broader access, broader coordination, all these things we always hear about, but we don't hear the how. We just hear the what. Connectedness, this is not about the internet, although a segment of it is, because there's a lot of folks in this country, in the United States of America, that do not have the kind of broadband, the kind of reliable internet that most folks that have these are used to. Internet is not a utility, it's not a public utility technically. There are folks that do not have access. So when COVID hit, I was the COO as a service of a behavioral health organization. We had about 100 patients a day, 7 days a week, outpatient, fully commercial group. When COVID hit, first commercial took a huge dive, different conversation. But the staff were really just used to coming in, clocking out. Didn't know that some of these folks didn't even have internet at home, our own staff. So within 3 days, I had to arrange hotspots and, an infrastructure to deploy. So when we're thinking about access to internet, folks that might not even really have access to those services. But connectedness is really about social connectedness. How could we live in a better, happier world if we ourselves are not happy or not, quote, better? This is the concept of human revolution. By having a revolution, so to speak, internally, by growing internally, by overcoming our own challenges internally, then by extension, we make a change externally. We impact those around us, those in the most immediate concentric circles. And when we think about the problems we're trying to solve, or a business idea, or another healthcare conference, how are we developing as leaders to actually address these issues? Because what's on the slide here is really just these bullet points. But as leaders, we will naturally come up with the solutions that will address our country's problems. So as long as we are committed to self-development and growth in the meantime, and that's how the best of ideas have come to fruition, via self-growth and development. And so the premise is that we cannot be expecting a happy world and a cost-effective world, depending on what conference you're in, they have their own world that they idealize. We cannot get there without self-reformation, to whatever that means to you. And I want to actually, let me see if there's anything on here. Okay, so this is, the biopsychosocial model is what, when you kind of saw the last slide, you could kind of tell the biology, the psychology, and the sociology, so to speak, the society in which, or the social determinants of health from which that individual comes from. This is our approach. So any kind of network model, any kind of business model, any kind of health plan contracting, any kind of business deals we do, we look at this first. Where does your solution fall within the biopsychosocial spectrum? And how can we enable the go-to-market for a given healthcare startup based on their clinical and operational model? So we can have a resilient future. This is our future. Our seniors are happy and resilient because our workforce is happy and resilient, because we approach communities as needing resilience and not just a drop of, aid. Or here's another product, and then, the company's sold and they disappear. Let me see. Let me ask you a couple questions here. You, sir, what's your name? Nick. Nick, what do you do?
He has a few businesses. One of them is healthcare consulting.
Excellent. Excellent, thank you. Nick is a healthcare consultant, also is an entrepreneur doing many things. Ma'am, what's your name? Monique. Monique, what do you do? Marketing. Monique is a great marketer. I could tell she's up here in front taking copious notes. Because, Monique, what is one of the greatest challenges you see in healthcare today, in the work that you do, or in your everyday life? She says it's hard because there's so many challenges. She's wondering if she only should say one. Sorry, what's your name, ma'am? Natalia, how are you? Great. What do you do? Excellent. Former clinician. Well, always a clinician. Clinician, always a clinician, but she doesn't provide clinical services anymore. But I could tell you're really resonating with this issue. So what we do as Carenodes is we work with healthcare technology startups that that come from not necessarily a healthcare background and want to do business in healthcare. And we help accelerate these startups into market by providing them with a medical director, should they need that. In some states, you need a clinical person. In Florida, I can own a clinic. In California, not so. I need to have a physician or licensed person now be owner of a clinic. We then provide health insurance contracting. Why? Because direct-to-consumer models, while very popular, are not very accessible for a number of reasons, including costs. So when I'm already paying my insurance premiums, my expectation as a consumer is to have access to my provider network. Often that's not the case. That's not the case, right? So for example, if you want to find a mental health provider, you might be calling around, they're not taking your insurance, provider might have expired quite some time and they're still on the directories, a number of issues. So as a mental health patient, I'm getting worse. I am. I'm not being able to get in touch with anybody. So we get the insurance contract set, network management set, so that our digital health organizations are able to take health insurance and able to charge copay as opposed to a full cash price, where either they lose money, they meaning the digital health company will lose money using a Uber approach. Okay, yeah, give a great discount, 3 years, and then take up the rates. Or the patient's out of money, like I probably shouldn't name names. Like X organization that charges $400 a week for texting your therapist. Not accessible, right? Not accessible. So we get health insurance contracts to make these services accessible. And then we provide our digital health organizations with that provider network I was telling you about, so they don't have to go worrying about, okay, what therapist should they recruit? Is this therapist an axe murderer in Arizona, but great in California, right? With this multi-state licensure, you have to be able to track sanctions all the time. So I know I kind of skipped over what we do at Carenodes because this isn't the Carenodes discussion. This is really a concern that I have for our country. And the intention here is to spur innovation. We're very open about sharing how we do things. The why is kind of obvious, but happy to share the why we do things. Because it's better for 1,000 organizations to take one step forward than one organization trying to take 1,000 steps forward. So with that, we have 10 minutes, according to this timer. And for the last 5, I've said, let's talk, and I guess it's just me talking. So I want to open up for questions. My expertise include managed care, health insurance contracting, digital health, and so on. So, yes, sir. Can I offer you this microphone? Just so we can hear you nice and clearly. Thank you. Hi.
Name is Ali Kazaizadeh. I'm a primary care physician. Thanks for your talk. It was interesting. What's the percentage of the service that you provide are telemedicine right now?
Good question. 99%.
Right. And do you have to go inside the people's home and see them as well? Or you do that type of service?
That's a great question, doctor. So we have the ability to go in the home if need be, but that's not our primary modality of our service delivery, simply because there are some areas that's very difficult to get to. So what we're looking for is partners, right, different parts of the country, where we can contract with, and if they have a mobile unit or somehow, capability to go to, some, for example, Nye County right here in Nevada, right, Prompt, Nevada, which you have one long 90-mile road that connects all things else. Then I'm more than happy to contract and expand our ability so that we can go in the home as soon as we can.
How many states do you guys
We're in 50 states.
Nice.
And DC.
Okay. Let's talk after this.
Let's talk. Thanks, doctor. I appreciate it. Yes.
I was wondering about your concierge service, whether it can be extended to patient compliance.
Excellent question.
And the other question is liability. Who takes the liability in those cases where you introduce intelligent techniques for detecting behavior and so on?
Good question. So the last question was, who takes the risk? Who gets sued for artificial intelligence or these, technology-based? I'm very passionate about that. Good question. And your first question, just so I could repeat?
The first question is about patient compliance,
Patient.
whether we can introduce a concierge for that.
Sure. So thank you for that. So there is this element of concierge care, and that was in the title of this speech or this session. Concierge care in managed care, right? Concierge care that's paid for by health insurance is really a movement around, okay, well, not everybody goes through the same utilization management process. Not everybody's indicators are so cookie cutter, right? So as healthcare providers, what we do is we take the risk from the health insurance company, right? We take the financial risk, and then we divvy up that, the dollars based on the patient's risk and what needs they might have, and then we kind of curate. So the patient compliance should not actually be a concierge element, should be standard across the board, right? So measuring the patient's compliance, let's say with medication or treatment plan. Is that medication or treatment plan? That should be a standard element. It should not be a concierge element. Now, if a patient has particularly, a hard time being compliant, and you find out by, I don't know, maybe you have pill bottles that are, kind of smart, and they could tell if the patient's taking the medication, or you have access to pharmacy claims to see if the patient refilled their medication. Those are some indicators of adherence or of patient compliance, and that's not a concierge element. That's a standard, across the board element. Now, concierge element would be if that patient has, a tendency to overuse medication, and then kind of as a concierge component, want to introduce maybe a substance or behavioral support element where not all patients would need, right? So does that answer your first question? So it shouldn't be concierge. Patient adherence should not be a concierge element, should be standard element.
Yeah, it's more about introducing the same techniques that you use for concierge. Like, for example, monitoring the patient at home, right? His movement, his behavior, what he's doing, his mental status, and from there relating to the patient compliance
I see.
with the medication.
Well, why don't we talk after this then?
Oh, sure.
Because that's interesting link that I'd like to draw kind of separately, because I want to be able to get to others. But let me answer your question about risk.
Okay.
Never should technology be created just for the sake of technology in healthcare, right? Technology should be created for the sake of a functionality in healthcare, for a need. And so I think that's like a lawyer, I should refer that to like legal technically, especially since we're on camera. But the practice of, underwriting malpractice insurance when technology is involved is complex and requires negotiations. And why don't I talk to you about that after too, just so they don't pull this video up and say, well, you said, but let's talk after the fact,
Yeah, sure. No
if
problem.
possible. Thank you. These are great questions. Yes.
Hello, hi, I'm
Hi.
Todd.
Hi,
I'm
Todd.
at the National Institute on Aging within the NIH.
Excellent.
And I manage a program where we provide over $100 million in funding to startups, developing age tech and other solutions. So one of my struggles, we probably fund over 50 startups right now developing digital care at home technologies.
Sure.
And one of my struggles is they're so, compartmentalized. And how can we as an industry kind of push these different startup companies to come together so you're not having care coordination completely separately from care navigation, as an example?
Can I take a seat for this? Because the NIH just posed a question. How do we aggregate all these startups towards a unified action, many embody one in mind? Yeah, no, that's a great question. The part of what we're doing at Carenodes is just that. We can talk later. No, we will be talking later. But the country deserves this answer now. It's a tough challenge because the folks that are generating these technologies don't come from healthcare backgrounds, which is natural. I mean, I come from the halls of Humana and clinics and hospitals and skilled nursing. When I started this company, I was trying to do one website. I needed to go to the tech people. They come to us. Ultimately, it comes down to an approach from the top line payers, and as long as they are carving out payments for behavioral and physical via two health insurance companies, you by definition don't have integration. I think your question is tied to integration. I appreciate you for not using the word integration because it's lost its entire meaning in this industry. However, it is the integration of operations with clinical workflows and some standardization from NCQA as to what are the standards for hospital at home, what are the qualities, what are the accreditation standards for bringing any kind of technology to people's homes where you don't have other clinicians or other staff looking at this machine or this thing saying, well, this is acting abnormally. The patient just has that one device or that one product. I definitely want to talk after this. So that we can have a unified approach in innovation. Thank you for standing for such a long time. What's your name?
Actually, in keeping with the last two speakers' questions,
Sure.
I was kind of curious about how, in a concierge space specifically, you might be addressing the kind of trend towards naturopathic medicine and alternative care, for example, like chiropractic care in the current COVID environment where people are, especially seniors, the elderly, are potentially less interested in going out and, there's the whole fear element. How can we deliver those? Is there something in your service that can help deliver those alternative services that people might feel have a value-added effect on their healthcare that we can maybe bring those services into the home also?
Yes and no. What a great question. Yes, in the sense where we work with organizations that provide doula networks, doula care, right? So that's your non-traditional kind of, maternity care team member. When I say non-traditional, every time I say non-traditional is what the health plans have not traditionally been paying for, because that's what drives service availability. If you're not going to get paid for it, you don't know how to generate revenues from it. As a business person, right, there isn't much of a business case. Now, Chiro, there's a huge movement on the Chiro side I'm very well connected with. Chiro, as a non-medication assisted treatment for opioid use, has been demonstrated time and time again in journals. Yet we still keep seeing medication-assisted treatment, which we should. Treatment options should be available and should be diverse. But chiropractic care, for example, is a very effective, I'm not a doctor, but look it up. It's a very effective form of opioid treatment, opioid use treatment. Now, how to bring these folks into people's homes is the reason I'm here, right? To generate and stimulate this discussion so that we can find ways to really scale this kind of infrastructure. As things are becoming more and more expensive, the prospect of sending someone to someone's home, the first thing you think about are gas prices. And so how will health insurance pay for the gas is the question in the boardroom, right? So is there anything you're doing in this? You don't have to come all the way here, just send me signals. Unless you want to. It's good for your steps.
We are
Helpful Hemp CBD company. Uh-huh. That's excellent. So natural medicine. Now, the thing is, we're in the West, and there's automatic resistance even towards people who are the most open-minded people, let's just say, in these boardrooms. I'll be signing the deals you need to scale this in an enterprise way. And they're thinking homeo, they're thinking home-based, they're thinking potions and pills. It really comes with education first. What does it mean? What are you treating? And what is your care pathway, right? So if it's this disease, what set of standardized operational and clinical protocol do you have to administer your treatment or your regimen? So there's definitely a pathway. And nowadays with, the cash concierge, medical concierge services that are about $20K a year, some have that kind of money. Perhaps there's some opportunity to collaborate with those kinds of organizations. But outside of that, there's a long way to go for non-pharma products in people's homes paid for by health insurance. And that's my main thing. How do we get you paid by health insurance? Because people are paying health insurance, you're paying your premiums, and then you're providing the service. So our business model at Carenodes is really around leveraging health insurance money to then drive multi-directional value in the market. Those are great questions. So let me see. In your experience as a clinician, she's like, me again. She's like, me. In your experience as a clinician, what is the most difficult, what is the challenge that you've encountered, even in your everyday life? And you're free to also opine. All of you, oh, how wonderful. Opine. Oh, you're all clinicians.
All private pay is insurance is not reimbursed.
Okay. I'm going to have you. Can you repeat that?
Yeah, all three of us are clinicians. We're all private pay because the insurance companies don't reimburse, or when they do, it's usually a struggle or reduced. There are so many aspects of working with companies that it doesn't work. I do a lot of concierge medicine. I have an internal medicine doctor that works with me, psychiatrist that works with me, practice, behaviorist, therapist. We go into homes, we stay in the clinic, we do a lot of teletherapy, and we have moved away. I tried health insurance for a while. I worked with some unnamed companies through health insurance, and it took 1.5 years to get paid, even 0.75% that we were owed, and so we dropped it. We said, we're moving away, and we have found that because of health insurance companies and the way they structure things, clients are much more willing to pay us first and seek reimbursement than going after a clinician who works with a health insurance company.
Sure. Thank you. This is exactly pointy case. You have providers leaving the system that you by law are required to pay for, health insurance. Leaving the system, so you have less supply, yet you have to pay now many more people. And I'm not talking about your subscription services. I'm talking about I'm not talking about your streaming subscription, sir. I'm talking about your subscription to your doctor. So you have your health insurance premium, you have your physician subscription, you have your Netflix, Hulu, HBO, Prime, Paramount. So is this really where you want to be headed? So as a senior person, like let's imagine me, at my 85, and I'm trying to access care. I might not have the wherewithal. I don't know what technology is going to be like then. To find this excellent clinician, this group of clinicians, to subscribe to them, to then have the financial means. My SSI check's $116.13. How am I going to afford my unnamed health plan premium? Some in this market, senior premium, in this market, $350 for MAP, Medicare Advantage PPO. And yet the physician doesn't get paid. So this is a systemic issue that will not be solved in the next 3 minutes and 43 seconds. However, we've made a tremendous headway here by talking about the issues in a way that's not so flowery all the time, right? We're doing integrations, we're doing, Health 3.4, health this and that. No, but ultimately the problems of Health 1.0 are still here, which is the physician who you depend on for getting care is not getting paid. And so, I mean, they're in this business because they've, they're to do no harm, right? They're here. Most of the most clinicians, not just physicians, clinicians I work with are in it because their heart's in the right place. They have some personal story. They have a reason. They've spent all this money to go to school, but they have not been trained on the aspects of business of healthcare because they're clinicians, right? It's not part of the curriculum. Yet they're thrown in a world where they have to fend for themselves to figure out if this contract makes any sense. For all they know, it may, because they only have that one contract as their sample to compare. When I went to Humana, I had 3,000 plus contracts that I compared. And when I saw the opportunity to do a better America, because the money is there, but it's not getting there. It's not getting to the clinician who needs to get paid. So I have a time for one more question. It looks like there's a minute left on this timer. Actually, why don't we talk after you and I? Because what I want to do is I want to open this dawn of a new era and encourage everyone in attendance here to take one step forward towards a future where when we need the care at that, not that we don't need care right now, I need care right now, literally. But when we're a little bit older, when we age a little bit more, our resources, our ability to, be agile, to be able to go and seek what we need diminishes even more. And so thank you everybody for being here today. I'm a resource to you. Our company website is carenodes.com. I'm on LinkedIn. I'll stay around to be connected. Because again, ultimately, my organization is not funded by any venture, anything like that. We're fully self-sustained, bootstrap, positive cash flow organization. And we like this position because we get to answer to our patients, to our providers, to our colleagues, as opposed to any fund. So let's work together, you guys, literally, to make this place a better place for when I might need that care at that age, or you or your loved ones. Thanks.